This is going to be the anatomy and physiology section of the comprehensive lecture for cardiology. So first thing we'll talk about briefly is risk factors and strategies for preventing cardiovascular disease. Obviously, we know that cardiovascular disease in America is one of the #1 killers of our population. So the decline in death rates from sudden death related to coronary heart disease may be related to increased preventative measures such as the medication administration that doctors are giving people for hypertension and for high cholesterol and that type of thing. But also it may be included, or another reason may be a heightened public awareness, because we teach a lot more CPR and a lot more heart health. We see it everywhere we go on televisions, billboards, and that type of thing. So hopefully that is having an effect. But even though the death rates have declined, coronary artery disease is still a major cause of morbidity and mortality because we live in the South and we have lots of barbecue and bacon and things like that that we love to eat and clog up our arteries. Also, you have to take into consideration the predisposed factors like age, sex, heredity for specific illnesses. So having a parent, obviously, just like we're just speaking of, with heart disease increases that risk factor, and so do some racial factors. And I'm not sure how much this is going to bear on you, but they felt it was important enough to include in this PowerPoint. So I think we should mention it. Excuse me. We do obviously. We have African American population who's more predisposed to hypertension, Mexican Americans, American Indians, Native Hawaiians, even some Asian Americans have a higher tendency to have heart disease than Caucasians. So how can we control these things? We can modify our lifestyle. We can stop smoking or remove ourselves and vaping and remove ourselves from environments where those things we might come in contact secondhand. And also we might be able to go to our doctor and, actually have that medical management, get those blood pressure medications or whatnot. We can always lose weight and exercise. That's never a bad idea. And then changing our diet can definitely affect, our heart health. So by helping support the education part of it and going out and informing, your population of small changes they may be able to make or whatever, you can actually have a big impact on cardiovascular disease in your community. So let's talk about anatomy and physiology. We'll briefly review the anatomy of the heart. We'll talk about the blood supply here. We remember that the heart is made up of 3 layers, and that's going to be an endocardium, which is the innermost layer that lines the chambers of the heart. That's where our conduction system is located. Then we have the thick muscular layer in the middle called the myocardium, and that's where the part that actually does the mechanical work of contraction. And we also have the outer layer, the epicardium, and that's where we have like our coronary circulation and those type things. We know that the heart is divided up in 4 chambers. There's a right and left atrium, a right and left ventricle, and that the heart itself is 2 individual pumps. We know that we have coronary arteries that feed our heart. There'll be a diagram of our coronary arteries here shortly. And those break down just like systemic circulation. Circulation of the heart goes through coronary arteries down to capillary beds and then comes back through the venous side as well and dumps directly into the coronary sinus, which the coronary sinus, just like the superior and inferior vena cava, empties directly into the right atrium. So here we have coronary arteries. The main ones that we talk about most of the time are, we look at our right coronary artery here, the circumflex branching off the left side, and our left anterior descending that feeds the front anterior portion of the heart. But one thing that we typically don't mention are the main vessels, the veins in the heart. And we have the small cardiac vein, the middle cardiac vein, the great cardiac vein. They didn't really get creative in naming them, but what we do want to remember is that all those cardiac veins dump directly into here, into the coronary sinus, which dumps directly into the right atrium, just like the superior and inferior vena cava do as well. So that's how our the blood that actually feeds our heart returns into circulation. So, like I mentioned earlier, the heart can be thought of as two pumps. One's a low pressure pump. That's going to be the right side, because which includes the right atrium and ventricle, because it just pumps a short distance. It goes to the lungs and back. That's its whole job. It wants to pump blood to the lungs to get it oxygenated and bring it back to the left-hand side. The left side is a high pressure pump. These are the ones where when we cut an artery, we see that spurting blood, because it is high pressure, because the left ventricle has to pump much harder than the right in order to circulate blood throughout the entire body. We know the right atrium receives venous blood from systemic circulation and the coronary veins, and that's going to be the inferior and superior vena cava. Vena cava are going to be the largest veins in the body. The inferior vena cava returns blood from the body itself. The superior vena cava returns blood from the head and shoulder areas. And this is kind of a diagram of what's going on, how it circulates around. You can see right here that we have deoxygenated blood returning to the right side of the heart. And the right side of the heart, all it wants to do is pump it out here to the lungs. Once the lungs, we have a gas exchange there, we dump off our carbon dioxide, pick up fresh oxygen, and then we're able to travel back around to the right side, which is our high pressure side, and that pumps all the way around to our body, and then obviously the process repeats itself. So talking about the cardiac cycle, talking about that pumping action, we talk about systole and diastole. Systole is when the heart is actually contracting, and diastole is when it's relaxing. So we think of a systolic blood pressure and a diastolic blood pressure, and the systolic number is always higher. The reason that number is always higher is because when the heart is actually contracting, there's more pressure in the vessels. And we'll get to preload and afterload in a minute. But I want you to think about diastole being the pressure in the vessels when the heart's at rest. So that's going to be related to the afterload we speak about here shortly. Obviously, heartbeat is 60 to 100 times a minute in a normal adult. And that with the use of valves and pushing through, we are able to circulate blood through our body. Here is I would pause on this and actually give it some thought. This is an excellent diagram of exactly how things are happening in the heart and when they're happening, with ventricular systole, the atrial diastole happening at the same place, then how the atrium fills up and then negative pressure starts pulling blood down to the ventricles through ventricular diastole. So hopefully that's a good graphic representation to help you understand a little bit better. So that cardiac cycle, just like we're speaking of, the ventricular systole and diastole, as the ventricles begin to contract, ventricular pressure exceeds atrial pressure. So that simply means that there's more pressure inside the ventricles than there is in the atrium, and so that backflow closes the valve. So the your AV valves, your tricuspid and bicuspid valves in between your atrium and your ventricles, that back pressure will actually closes the valve, so the blood is not allowed to move backwards, and so it has no choice but to move forward. Good thing for you to know, you need to know what stroke volume is, even though you can't calculate it out there accurately in a pre-hospital setting. There is a general formula that will help you treat all your patients. And stroke volume is simply the amount of blood that is ejected from the heart each time the ventricle contracts. Okay, so the volume of blood in one specific contraction. So what affects stroke volume? Okay, preload. Preload is the amount of blood, or the pressure of the blood, returning to the heart. You'll hear when you get into pharmacology, you'll talk about nitro, and people say it's a vasodilator, and that's what it does. Well, it is a vasodilator, and that's its action, but one of the big things that we want it to do is to decrease preload. And why we would is because of Starling's law that's mentioned here on your slide. According to Starling's law, myocardial fibers contract more forcefully when they are stretched. We call it the rubber band law. If you stretch a rubber band a certain amount and you let go, it pops back. If you stretch it a little bit more, it pops back harder. So Starling's law basically has this effect on stroke volume. If you increase the amount of blood returning to the heart, then the heart stretches farther, and then the heart contracts harder. But that does increase work on the heart. Obviously, you can reach a threshold just like you can with a rubber band, where you get to a point that the muscle tissue is actually damaged and it's unable to contract back if it's over inflated, which is where like hypertension can really come into play in long-term patients. Afterload is, we mentioned earlier, is the pressure within the aorta before the ventricular contraction. So during diastole, when there's nothing affecting the system whatsoever, the pressure that's in the aorta is afterload. So that means afterload is the pressure that the heart, when it contracts, has to overcome. If you have a blood pressure of 120/80, that's great. That means that when the heart's at rest, the pressure in the aorta is 80 millimeters of mercury, and the heart has to contract and push at least 81 to move any blood whatsoever. And so therefore, a pressure of 120/80, we can see that we have 40 millimeters of mercury greater pressure in that difference between the 120/80, where the heart was able to overcome the pressure in the aorta and actually move blood along. So the greater the afterload, obviously, the more difficult it is for the left ventricle to pump to the body, which once again, when we talk about things like hypertension, we always remember that having a really high bottom number for an extended period of time can be much more dangerous than having a high top number. Myocardial contractility is basically the unique function of the heart muscle itself, that middle layer, the myocardium, and the influence on the of the autonomic nervous system into actually depolarize and contract. Okay, so ischemia or various drugs can obviously decrease or increase myocardial contractility. And ischemia can also reduce the total number of working myocardial cells, such as if a section of the heart during an MI was deprived of oxygen, then those cells wouldn't be working as well. And that means that they wouldn't be contracting and pushing blood as effectively. Hypoxia or beta blockers can decrease the ability of myocardial cells to contract as well. Cardiac output. We talked about stroke volume. Now let's talk about why it matters. Cardiac output is the amount of blood that is pumped by the ventricles in 1 minute. Everyone's cardiac output is different. My cardiac output is different than yours. Yours is different than your sister's. Your sister's is different than your friends or whatever. But our cardiac output is ideal for our specific body. That means that the amount of blood that is pumped in 1 minute is the exact amount of blood that our body needs in order to oxygenate and carry nutrients to every in our body. That's not just including our heart and lungs, the important ones, our brain, but kidneys all the way down to our skin cells and hair follicles. Everything has to have an appropriate amount of oxygen, and it has to have an appropriate amount of nutrients. And so our cardiac output is designed to do that. So cardiac output is stroke volume, okay, which is the amount of blood pumped in one stroke or one contraction of the heart times heart rate. How many times does that happen in a minute? Why is that important? Because if anything happens in our body, i.e. shock or whatever, that reduces stroke volume, suppose we have some kind of blockage, an obstructive shock, some kind of like sepsis, a distributive shock where the blood pressure starts to drop, that preload is decreased and there's less blood returning to the heart. Less blood returning to the heart is going to do what? It's going to decrease stroke volume. So how does our body respond? Our body increases heart rate in order to balance out that equation. So it's really important to remember cardiac output is stroke volume times heart rate and what it actually does. So what makes that heart rate go up? The nervous system. Nervous system controls our heart rate. Okay, we have our cardiac conduction cells have a property known as automaticity. Automaticity, write it down. And that means that they have the ability to generate their own electrical impulse, and they don't have to have someone else or something else telling them how often to fire or contract. We have pacemaker sites like the SA node and the AV node that we'll get into shortly that actually generate their own signal causing the heart to contract. But what controls that rate? The autonomic nervous system does. And we know that the autonomic nervous system has a sympathetic branch and a parasympathetic branch. And that sympathetic branch, whenever we have an issue, our body goes, oh, well, this certain tissue is not getting enough oxygen or nutrients. What has to happen? our vessels need to contract, and our heart rate will increase. And that's done by our sympathetic nervous system releasing norepinephrine and epinephrine directly into our bloodstream to increase that heart rate and contractility. The parasympathetic nervous system is basically the reins that pull back on that all the time. A good thing to remember is that the sympathetic nervous system affects the atria, heart rate, and ventricles, that contractility, whereas the parasympathetic typically just mainly affects the atria in slowing the heart rate. So we know that the vagus nerve is the 10th cranial nerve, and it is the primary nerve of the parasympathetic nervous system. And so like we have drugs like atropine that work directly on the vagus nerve parasympathetic response. So please keep in mind that parasympathetic control of the heart is accomplished through that vagus nerve, that 10th cranial nerve, which is another fun fact why people that atropine wouldn't really work on someone who had a heart transplant, because in most cases a heart transplant, the vagus nerve is actually cut. Sympathetic nervous system is found in ganglia along the spinal cord. And everybody knows the whole sympathetic fight or flight, release of adrenaline, increases heart rates, this, that, and the other. Good thing to remember, though, is that anytime that a heart rate is increased to a greater than 150 beats per minute, the time available for the heart chambers to actually fill is decreased, so that can actually decrease your stroke volume. And all this is controlled by hormonal regulation. Okay, so impulses from the sympathetic nerves are sent to the adrenal medulla. At the same time, they're sent to all the blood vessels. So that's the heart rate, and the blood vessels are that vasoconstriction that I mentioned earlier. In response, the adrenal medulla secretes the hormones epinephrine, norepi into circulating blood, and then this can be due to physical activity. You can be stressed out, excited, whatever. The body responds in the same way. And that epinephrine has basically the same effect on cardiac muscle as norepinephrine does. And in come the electrolytes. Let's remember that the big ones that we talk about are sodium, potassium, calcium, and to a certain degree, magnesium. I like to remember that the sodium and potassium are responsible for the actual cells contracting, and the influx of calcium is primarily responsible for actually how hard or that happens, or the contractility of it all. Now let's get into a little electrophysiology. This can be a little overwhelming if you don't take it in pieces and small steps, but it's not that complicated. Basically what we're going to be talking about is we're going to be talking about cardiac cells and membrane potentials. Okay, big words, whatever, but the membrane potential is nothing but the cell membrane of a cardiac cell and its potential to let things move across it quickly or slowly. Okay, we're just talking about voltage. So electrically charged particles, we know, work kind of like magnets. If you have a positive and you have a negative, they stick together. If you have if you've everybody taken two magnets and turned one around and tried to push them together, they didn't stick together, they pushed apart. That's because you were pushing a positive against a positive or a negative against a negative. Okay, and so let's think of the magnet rule when we talk about sodium and potassium. So we have a resting membrane potential, all right, and this is when the cell's in its resting state. The electrical charge difference is the resting membrane potential. All right, so that means that the difference in voltage from the outside of the cell to the inside of the cell is at its potential. It's ready to fire. Okay, so the inside of the cell is negative compared to the outside of the cell. That's because we've got magnesium and things like that. They're negatively charged, and so they're on the inside of the cell. And typically a resting membrane potential is about negative 70 to negative 90 millivolts. Okay, that just simply means that it is more negative than the outside of the cell. You very well may never see that number again, but the concept of it is you need to remember the inside of the cell is more negative than the outside of the cell. There are more positively charged particles on the outside. So we have diffusion of electrolytes through ion channels. Okay, ion is nothing but is an electrolyte. It is a positively positively or negatively charged particle. Okay, a cation is a positively charged particle, an anion is a negatively charged particle. Okay, and the cell membrane is relatively permeable to potassium, which means that it goes back and forth pretty much at will. It's little calcium has to work a little bit harder, and sodium has to actually be, in most cases, transported across the cell membrane because it doesn't because it's too large. So the cell membrane appears to have individual protein-lined channels. This is that sodium potassium pump that we hear about. We have fast and slow sodium potassium channels. So these channels allow passage for a specific ion or group of ions, which means that a sodium channel only allows sodium to influx inside the cell. And they open and close by being triggered by gating proteins. So the sodium potassium pump, okay, normally transports 3 sodium ions out for every 2 potassium ions taken in. So you think about that. They're moving more positives outside the cell than they're bringing inside. So the inside of our cell is negatively charged. I have some diagrams to show you this, to explain it a little better here in just a second. But this action repolarizes the cell and returns it to that resting state we talked about. Remember that membrane potential? So how does pharmacology play into all this? In cardiac muscle, sodium and calcium can enter the cell through 2 separate channel systems. They're fast and slow, okay? Fast channels are sensitive to small changes in membrane potential. That means that all of a sudden our cell depolarizes. Now our cell, the inside of our cell is closer to being positive or closer to matching the outside. Then what happens? Then our sodium potassium pump starts pulling in sodium and pushing out potassium, and therefore and starts returning it back to that negative. So rapid changes can open the fast sodium channels, and it can pull sodium in and, for rapid depolarization. So here we go. These are the phases of cardiac action potential. All right. I want you to understand that this is not a graph that you're going to see on a monitor. Okay. This is just simply a visual representation of what is going on voltage-wise in the heart, just to help you understand how it's polarizing and how it's repolarizing and that. So don't let it become overwhelming. So all we're looking at here, if you note on our slide, this green line is going to be our voltage as our heart contracts. You're not going to see that on a monitor, okay? But we will see underneath how it relates to our QRSs and T waves, and that we actually do see on our monitor. So cell excitability is basically a cell's ability to respond to stimulation. How excited is it? Now, overexcitability can become irritability, right? So we could have like something somewhere in the heart that becomes irritable or overly excitable. Kind of means the same thing. Start, firing or doing something that's not supposed to, and start throwing it off. And that's where our dysrhythmias come into play. So let's talk about phase 0. We just saw our diagram, and there'll be more, but phase 0 is the rapid upstroke of the action potential. That is when the cell membrane reaches its threshold potential. That sounds complicated, right? It just simply means that, bam, we're ready to go, okay? That's all it means, is we're ready to go. So phase 0 is depolarization. All right, it begins when the cell receives an impulse. Where does the impulse come from? It's that signal that comes down the conduction pathway and says, tag, you're it, it's time for you to contract, okay? And so that means sodium is quickly sucked into the cell, potassium is forced out of the cell, and calcium slowly moves into the cell. And there's also calcium that resides inside the cell all the time. But this is where the cell depolarizes. Contraction begins. Phase 0, bang. This is where we see phase 0 is what causes the QRS complex on our ECG. So then we have phase 1 and phase 2. Phase 1 is that early rapid repolarization. Everything's starting to reset really quickly. And then phase 2 is the plateau phase, okay? This is the prolonged phase of repolarization. So basically what happens is phase 0, our cardiac cell fires. Phase 1, it quickly starts to repolarize, but then it kind of levels off, calms itself down, and the repolarization becomes more gradual. So we can see it here. Phase 1, that's that early right here. We see that early repolarization, how it spikes really quickly. But then we plateau off on phase 2, okay? And that is our sodium channels partially closed. We have a brief outward movement of potassium, and we have fewer positive electrical charges going on. Phase 2 is the plateau phase we just talked about, okay? And this is repolarization continues relatively slowly, all right? Starting to bring in some more calcium, starting to move a little more potassium out, okay? And there's a diagram that you can check or you can kind of look over and study. Now let's talk about phase 3 and 4. Phase 3 is the terminal phase of rapid repolarization, okay? So we're reloading. Think about depolarization as we're bang firing. Repolarization as we're reloading, okay? So phase 3 is the terminal phase. That's where rapid repolarization ends. And then phase 4 is that period between action potentials when the membrane has returned to its resting state and it's ready to fire again, okay? So we have phase 0, bang, we fired. We quickly start to reload. We finish reloading in phase we quickly start to reload in phase 1. We continue reloading in phase 2, and in phase 3, our reload is done. In phase 4, we are at our resting potential again and ready to fire. And here we go. Okay, there's our we have the final rapid repolarization. All right, calcium flows quickly out of the cell. All right, the entry of potassium, the entry of calcium and sodium is stopped or whatever, and this is the T wave. All right, phase 3 is the T wave. We think of the T wave being repolarization, but it's actually electrophysiology of the heart. In relation to that, the T wave is the end or the final section of rapid repolarization. And then phase 4, we return to our resting state. The heart's polarized during this, and it's ready to fire again. And it's going to sit there in this state until reactivated by another stimulus, which means that the heart's conduction system has to send another signal down to tell it to bam, depolarize, and start all this over again. So let's talk for a minute about refractory periods, okay? Basically, I like to explain refractory periods as in this is the I use a firearm analogy, but it works. So refractory period is basically a reload, okay? All tissue that's excitable, that can fire or whatever, has to have a resting period. And we call that resting period a refractory period. It's when it reloads. And we have an absolute refractory period, okay, which and the thing to remember there is cardiac muscle during the absolute can't respond to any stimulation. I'll explain that in a second. And the relative refractory period is when everything is kind of getting back together or whatever, and the body is able, or the heart is able to respond if for some reason something were to pop off in or fire erratically, that's where we start having our dysrhythmias. So with the absolute refractory period, I think of it as we go, when we fire a gun, bang, we have discharge. Now note that this is on this diagram right here, we're seeing our QRS that we would see on a monitor when we were running EKG. But up here we have the electrophysiology, that voltage diagram and how it correlates. Okay, so from the time our QRS fires, okay, from the time we pull the trigger on our gun, okay, when we pull the trigger, nothing can stop that explosion. Nothing can stop the bullet from being pushed forward. Nothing, anybody who's familiar with semi-automatic firearms, nothing can really stop the action from being pushed backward, all because of that explosion, okay? So basically what happens is we have right here at the beginning of our depolarization, here we have our gun firing. And then we have that first section of reload where the slide is thrown back and all this kind of stuff. And it's absolute. Nothing can stop that from happening. However, as we move forward, we have relative refractory period, and that's where our slide of our gun starts to move forward again. The bullet raises up, wants to go back in to get back to a resting potential, ready to fire again. However, if something were to cause that, that could jam, or we could have I don't know, dirt, something get into our action or whatnot, then that could cause our next wave to fire early or not fire at all. I hope that makes sense. If not, just keep in mind, absolute refractory period is that portion goes from the beginning of the QRS to about the peak of the T wave, and nothing, any ectopic beats or anything, can stop that section from happening. However, on the back half of our T wave, on our relative refractory period, this is where we're almost reloaded. So if something somewhere sent a signal that was out of order, it could actually affect our underlying heart rate. And that goes from the peak of the T wave to the end of the T wave. So let's talk a little bit about the electrical conduction system. We have a sinoatrial node, which is known as the heart's pacemaker, and we have an AV node, which is the top of the bundle of the AV junction in correlation with the bundle of His. And basically what happens is we have the SA node that's located in the top of the right atrium, the AV node located in the floor of the right atrium, and both of those are in that innermost layer of the heart that we talked about earlier, the endocardium. And here's an example of it. We have the SA node here. We have the AV node here along with the bundle of His, and this is the AV junction. That's where our delay comes in, our PR interval, if you will. The bundle of His has an inherent rate. Here we have our right and left bundle branches, and we have our Purkinje fibers that actually penetrate into the myocardial tissue, or the myocardium, that muscle. So the SA node sends a signal down the conduction pathway. When we get right in here in the AV junction, that is delayed, and now that signal is allowed to travel down the bundle branches all at once, hopefully, so the ventricles will contract together. So pacemaker activity. Please remember that we talk about the SA node being the pacemaker of the heart, because that's typically, it repolarizes and fires more quickly than the other the lower portions of the conduction system do. So that's why it's typically, we call it the pacemaker, because it fires on average 60 to 100 times per minute, because the average heart rate is 60 to 100 times per minute. Now please remember that any other site in the heart that suddenly starts firing erratically or whatever, and is firing faster than the SA node, will be called a pacemaker site. And that's what, when we get into dysrhythmias, will be explained a little in more detail. The autonomic nervous system has effects on the pacemaker. We already covered all that, how the sinoatrial node is the portion that's affected by the sympathetic and parasympathetic. Okay, and there's that word again, that automaticity I mentioned. Okay, enhanced automaticity is caused by an acceleration in depolarization. So that means it's ready to fire more quickly, and there's a signal telling it when to do so. Also remember that the autonomic nervous system is epinephrine. Epinephrine is adrenaline. So we talk about things that have adrenergic effects. Adrenaline being related to the sympathetic nervous system. Acetylcholine is the neurotransmitter for the parasympathetic nervous system. That's acetylcholine, and we talk about cholinergic effects. So anytime you see cholinergic effect or hear that, you know that it's related to the parasympathetic nervous system. And then we have reentry. Okay, and reentry is basically a signal that got sent out that for whatever reason was blocked, or could not progress down the pathway the way it needed to. And so therefore that signal might find a different pathway and travel back up. So that can cause lots of different issues. You talk about WPW in different situations when you get to them, but basically just know that the term reentry means that it is the reactivation of myocardial tissue for the second or subsequent time by the same impulse. That means the same signal went down and it couldn't travel as far as it needed to go, and so it was recycled and reactivated that same tissue, and you might have some premature contractions. And that is the end of your anatomy section of this or whatnot. We will conclude here and move on some